Good afternoon, everyone. I'm Noor Al-Azzam, CEO and co-founder of NanoMood. Joined alongside me is my sister, Shams Al-Azzam, also co-founder of NanoMood. And together, we're on a mission to bring new solutions to mental health care. As we know, 1 in 4 individuals in the US have a mental health disorder, with the high prevalence in anxiety and depression. Globally, this costs over $10 trillion. The bottleneck lies in the limited number of psychiatrists per patient. Thus, the burden falls on primary care, where they have to attend to 80% of the patient population pool. And with limited expertise, they still have to manage, monitor, and treat. And this is a much needed solution in this space. What we need is an objective, sensitive, and scalable tools, such as digital health tools, that's able to improve the precision of diagnosis, can reduce the cost of diagnosis, and improve the prediction of disease progression. And this is where NanoMood comes in. Our approach is quite simple. We capture, we analyze, and we provide personal interventions. So our approach takes a multimodal approach that takes both passive and active data, funnels it into our AI-powered platform that provides a symptoms report. And in that symptoms report, we have risk stratification of that patient, and we can match them with the right treatment. And so far, we have been fortunate to have many agencies support us, including the NSF, VentureWell, and recently just joined ARPA-H. So just to give you a glimpse in our patient support, clinicians can use this to remotely monitor their patients and can be easily digestible for them. So far, we have 3 pilot studies, each one with different goals. One is in the VA, where we are focused on PTSD relapse. The second one is in a private clinic, primary clinic, where we're taking our multimodal approach in looking at patients with depression. And our third one, a just recent partnership with UCSD Health Innovation to bring a mental health app to students. So why are we here, right? We are here to ask for a matching fund of $275,000 to match our NSF SBIR grants. With that, we can bring on 2 ML AI engineers and help with our current partnerships, but our future partnerships and collaborations as well. So with that, I had really the pleasure to working with amazing individuals at NanoMood, one being my sister. And we have over decades of experience in clinical psychiatry, computational science, and as well as commercial. And with that, scan the QR code, check us out, and let us know if you have any questions. Thank you.
Did I miss anything on the competitive landscape?
Oh, we have that slide saved just for you. Yeah. So currently, I'm sure you know, this is what our competitive looks like. We have it in almost like many brackets. So you have both in the biomarker platform, where we stand currently, and our biggest one is Field Therapeutics. So far, they're a bit ahead of us, and our clinical use platform. And so that really kind of separates us between the other folks around.
Well, building on that question, can you talk a little bit more about your moat? Like, how are you protected? How are you differentiated from these other companies?
Yeah, sure. That's a great question. So our biggest differentiator right now is the way we're capturing the data. So we're looking at a multimodal approach. As you know, in mental health care, these tools are not even available right now. It's predominantly a question, what we call a pen and paper approach. So patients will come in, answer certain questions, and that's how they're diagnosed, monitored, and so on. So our approach is to capture as many data as possible. Our most reliable data sources are wearable data. So in our pilot study, as Noor mentioned, with a clinician, he actually has on some of his patients 3 years plus worth of wearable data on these patients that are undergoing treatment. So he has data on them at baseline, during treatment, and after. So what we're doing right now, and this is still in progress, we're looking at the patterns from baseline, treatment, post-treatment, and that's where we're providing the insights. Compared to our competitors, they're doing similar approaches, like the biggest one, Field Therapeutics. They're also leveraging wearable data. We're bringing another aspect. So we're taking biological data, we're taking behavioral data, we're taking interview data. So we're collecting all these types of data to give us what we consider a holistic understanding, because we believe one data source is not really enough.
So how are you handling the shortage of psychiatrists, psychologists, and really that 80%, right? Understand collecting the data, identifying, but what value are you bringing to primary care and also filling that gap?
Yeah, I mean, that's a good question, right? So right now, primary care, they lack the expertise. That's number one. So right now, our pilot is literally trying to understand, where do we meet that sweet spot, that value? Is it the symptoms report they're looking at? Is it matching the patients with the right treatment? Is it even making sure they're making the right diagnosis? Because we know if you have multiple psychiatrists in one room and one patient, they're all going to have different diagnoses. So how do you even standardize that? And actually, last week, we went to APA, that's American Psychiatric Association. And this was all talked about. They want this. And in fact, primary care is really positioned to be at that, because they capture the biggest pool before they even refer them out to a psychiatrist. And that's 2 to 3 months, just FYI. So they're still in the hands of primary care, and they're still being managed, they're still being treated. And so they don't have individuals like us that are coming in. And that's how we started. We really went to Michael, the primary care physician that we work with. His patients already come with Oura Ring data, and he doesn't know how to analyze it, but we do. So I think that is when we're coming in, is that sweet spot. Now, the primary care physicians that we are working with, the patients are at a higher tax bracket. They're rich, they can afford it. So they'll pay out of pocket. What we really want, and that's why our partnership with ARPA-H is really important, is that we want to reach the individuals that actually struggle with mental health care and the social economic status that they have, they can't, right? And so ARPA-H comes in by giving you that incentive to really help in that geographic area that's really much needed.
Could you talk a little bit more about the business model?
Yep.
Or a little bit more if you're proving that out in ARPA-H, just on that project?
So right now, the way we're thinking of a business model is a B2B, although we are working with directly private care on an individual level, so directly with the primary care. We believe in order to reach scalability, we have to reach bigger healthcare systems, like the hospital systems. Although we've talked to some healthcare providers, our customer interviews haven't really been definitive about what their pricing looks like, how we can package it, that sort of thing. So this is work in progress for us. But the way we're approaching right now, just from working with primary care physicians, as Noor mentioned, a lot of their patients pay out of pocket. So the primary care will charge actually just to analyze some of their data, and that is on a monthly basis. Some of the primary care that we work with are very smart about optimizing on the reimbursement code, so they know how to use this. To our knowledge, we're not familiar with that at this point, but that's something we're working closely with them to understand how they're reimbursing. There are some limitations and barriers to entry, I should say, but we are working with them to see how they're reimbursing, how is that working, how should we cost it. And right now, to get a rough estimate, we're estimating that it's gonna, if we were to develop our revenue stream, we will potentially charge per patient on a monthly basis. And that's kind of correlates to what the clinicians that we're working with are kind of charging the patient currently. So, but these are rough numbers. We don't know how that's gonna pan out as we scale up. So this is just take it with a grain of salt for now.
So you guys, thank you for working on this. The mental health burden on the healthcare system is staggering right now. And there's clearly a mismatch between demand and available supply. And that difference is not going to be made up by just better triage, but it appears that you have a device or a methodology where better triage may be possible. Meaning if you're able to striate the patients between those that require relatively low level of intervention versus higher levels of intervention, that's going to be a very key ability for us to be able to differentiate, i.e. improving the efficiency of that care by matching the demand with the appropriate interventions that are necessary. I think you guys are onto something. Having said that, what's your training set, your data training set, and the applicability of that training set to the various cohorts that you guys are purportedly able to triage? And what are you using as a test set for accuracy of those diagnoses when sometimes the behavioral specialists themselves have some difficulties in determining what that diagnosis is?
Sure, I'll work backwards. So when we talk to clinicians initially, we ask them a question: what kind of accuracy do you look for? And they said, if you can achieve, just give me a 75% accuracy, I'll be more than content with looking with that. So what we did from that point on, when we initially started NanoMood, we worked with what was available to us. And at that point, we had a plethora of publicly available data sets. Noor and I are both PhDs, so we are in the scientific area. We both work with data. We have access to all these researchers. So what we were able to do is we leveraged them. Really, we talked to them. We said, what data do you have? What can you share? And we captured all those data, working closely with the VA. So Dr. Colin Depp, who sits on our mentor board, he actually works closely with patients with PTSD, with depression. He leverages wearable data. He has access to digital data. So we worked with our network of researchers, both in the VA and then UCSD Health. And then from that point on, we start to progressively kind of move from there to starting to get access to what we consider private data. So we were able to sign some data release agreements with the VA, with the clinicians we work with, so we can actually securely work with that data. So there are some limitations. Some of that data we can use for training. The public data sets, yes, of course. But the private data sets, it depends on the release agreements that we signed. Some of them allow us, some of us say don't use it for training. We are trying to stay in communication with the UCSD Health. Right now, they mentioned that they have over 9 million patient data that we're working to kind of get access to a portion of that. So we're trying to build these contracts with them. We don't know how these are going to look like, and it's all really going to depend on funding, because right now we've reached a capacity in terms of getting that data. The next goals for us is like, how are we going to start computing? And I think that is a bottleneck for us from a cost point of view, because we need to start acquiring our GPUs, develop the models, optimize the models, train them, look at the accuracies. But right now, from an accuracy standpoint, so when a clinician says we're looking for 75, we're able to deliver 85%. So we're right now meeting them at their sweet spot, but we're always working on improving that. And I believe with more training, more data sets, especially high quality data, which are very hard to combine, but we're hoping that through our current pilot studies, we can achieve some of those samples that can drive some of that, milestones in terms of improving our accuracy downstream.
So it's great that, so you mentioned the 3 pilots, which is a great starting point. Pilots are notoriously difficult to convert to paying customers, especially in digital health. Have you defined any specific impact or success metrics to call the pilots a success?
Yeah, I mean, that's a good question. So the DO we work with, actually, I'll give you a story about him. He's interesting because he's precision medicine, right? That's the clinic that he runs, like if you were to kind of do it. The first person he actually hired was a data scientist. He didn't hire a nurse. Who needs nurses? I mean, we do need them, but the first person who really hired them was a data scientist. And he made that decision because he knew a lot of his patients want quantitative data. And so what we talked and communicated with him, if we have a success in his clinic, he can go to 100 clinicians and get our platform into their clinic as well. And so that to us is already a huge milestone, right? And so once you can prove yourself well in a clinic, clinicians do talk to each other. So it's a word of mouth that will spread. And so that's really our initial of how we can scale to more private clinics. Not to say that we are always going to rely on private clinics. This is, of course, our entrance, but we're always, again, we work with the VA for the past 2 years, and the VA is always looking for innovations like ours. So that's already an entrance into that bigger, more structured hospital system.
Great. Thank you very much, guys. That was an amazing presentation.